Welcome to the Weight Loss Surgery podcast, where we talk about obesity and bariatric surgery, one episode at a time. I'm your host, family nurse practitioner Rieger Cortell. This is episode 79. I'm starting this new year, 2017, off by giving you a podcast version of the Bariatric Surgery introductory seminar that I give twice per month at Southern Oregon Bariatric Center. I've edited this podcast version so that it's more generic for bariatric surgery in general, meaning other than mentioning SOBC right now, I won't be talking at all about Southern Oregon Bariatric Center's program specifically. If you are someone who's considering bariatric surgery and you want to know more, this episode is definitely for you. If you want your loved ones to understand more about your choice to have bariatric surgery, this episode is totally for them. And I want to mention that I think this episode is going to be around an hour long, which perhaps sounds like, OMG, what could she possibly talk about related to bariatric surgery that takes an hour? Well, quite a bit. And this is definitely only going to be an introduction / tip of the iceberg introduction. If you're going to undergo bariatric surgery at some point in your future, please know that it will significantly change your life and you, all for the better, we hope. But as such, when you're going to radically change your life, get the education that you need in order to be prepared for that as much as possible. And that's what this podcast and this episode is definitely about. Now, this presentation does correspond to a PowerPoint presentation. While I'm recording my voice right now, I am recording this as a video PowerPoint presentation, which I will be posting to my YouTube channel at some point in the very near future, perhaps even the same day that I hit publish on iTunes to this podcast. So if you want to check that out, go to my YouTube channel, Rieger Cortell, or I will post a link to the YouTube PowerPoint presentation on my website at weightlosssurgerypodcast.com. And before I begin the seminar, I want to give a shout out and huge thank you to my new patrons who've taken their appreciation of the podcast to the next level by offering financial backing at patreon.com. So thank you to Della and Ken. Awesome. So appreciate your support. If you, dear listener, want to support the podcast for as little as $1 per month, please go to Patreon, that's patreon.com/Rieger. Okay, now let's get on to the bariatric seminar. What you're going to learn today. We're going to talk about obesity, the extent of the problem. We're going to talk about why we become obese and the misguided messages of eat less and exercise more, how and why bariatric surgery works, and what your surgical options are. And I want to give you a heads up that my focus with this episode is going to be on Roux-en-Y gastric bypass and vertical sleeve gastrectomy. I'm not going to talk about revisions. I'm not going to talk about gastric banding. I'm not going to talk about gastric balloons or any other procedures. And my reasons for that is one, timing, and two, a lot of the science that I'm going to be talking about really applies to what we know at this point of Roux-en-Y gastric bypass and vertical sleeve gastrectomy. Okay. Now, obesity is defined as a BMI of 30 or greater. And if you don't know what your BMI is, then you can just go to Dr. Google and put in BMI calculator, and you'll be able to put in your height and your weight, and your BMI will pop up. Now, in the United States of America, more than 1/3, or 78.6 million adults are affected by obesity, and 17% of our youth. And when you combine people that are overweight and obese, the numbers go up to 68.6% of our population. So this is a significant problem. The costs related to having obesity are estimated to be $147 billion, and that's in 2008 dollars, and that's medical cost associated with obesity. So this is very costly. Now, as you probably know, obesity is not necessarily a standalone disease in and of itself because it comes with some, air quotes, friends, or we could call them frenemies, certainly. People that are affected by obesity are also significantly more prone to develop type 2 diabetes, high blood pressure, heart disease, respiratory diseases, cancer, stroke, arthritis, urinary incontinence, infertility, increased risk for accidents. Now, to mention that, clearly that's not a disease, right? Increased risk for accidents. But if your body is carrying around 100 extra pounds and, you step off a curb and maybe you're momentarily distracted, you are at increased risk for taking a funky step and going down and blowing out your knee, injuring your back, etc. Simply carrying that excess weight does increase a person's risk for accidents. It also increases the risk for kidney disease and depression. This is not a very happy list. Now, the mortality facts, it's not surprising that recent study concluded that obesity in adulthood is associated with a decrease in life expectancy of up to 10 years in both men and women. Now, when we look at the obesity epidemic and what's been happening, particularly with an eye on the United States of America since the mid-1980s, we've got some picture graphs that we can look at. Now, in 1985, the Center for Disease Control, the CDC, started tracking the trends of obesity rates in adults in the United States. And 1985 was the first year that they put out these numbers. And it was only about 20 states that reported their obesity rates. And about, of those 20, I'm going to just eyeball it here, it's about 12 states were reporting obesity rates of 10 to 14%, less than 10%, and 6 states were reporting obesity rates of 10 to 14%. The rest of the United States hadn't yet reported their obesity rates in adults. Flash forward to 1997. Now every single state is reporting their obesity rates. Greater than 50% of the United States has adults with 15 to 19% of the adult population in those states have obesity, and 3 states have obesity rates with 20 to 24%. Go then to 2003, greater than 50% of the United States has adult populations with 20 to 24% obesity rates. And now we see 4 states that are reporting adult obesity rates of 25 to 29%. 2007, now significantly more states, greater than 50%, report obesity rates in adults of 25 to 29%, and we now start seeing 3 states reporting obesity greater than 30% in adults. And then in 2014, we see an uptick again, more states reporting 30 to 35% of their adults have obesity, and we start seeing 3 states that are saying their statistics are greater than 35% of the adults. So the trend so far since we've been tracking it in the mid-1980s is an uptick significantly. And this begs a really important question of why. What on earth has been happening? And in order to answer this question, we actually have to turn a little bit to some physics. I know, everybody's favorite subject, right? Specifically, the first law of thermodynamics, which is known as the conservation of energy. And conservation of energy states, and bear with me here, the change in internal energy of a system is equal to the heat added to the system minus the work done by the system. Okay, now, if you're thinking, what? I just lost you. I'm here to tell you that if you're somebody who's affected by obesity, you have told yourself or other people have told you repeatedly something along the lines that apply to the first law of thermodynamics, conservation of energy. When you have been told, well, if you want to lose weight, you eat less and move more. And if you're gaining weight, it's because you're eating more than you're moving. That's the first law of thermodynamics. That's conservation of energy. And we can't deny physics. It's true, okay? And it's so simple, right? If you eat more than you exercise, you're going to gain weight. Simple. Now, similar to running a marathon, right? Put your shoes on, head out the door, go 26.2 miles. Simple. Okay. No, not so much, right? Because even though a person might tell you, well, if you want to lose weight, you just eat less and exercise more, and it's so simple, just like running a marathon, that does not make it easy, okay? So it's important to not confuse simple with easy. Now, it is possible to lose weight by eating less and exercising more. And we celebrate those people, right? We put them on the cover of People magazine, and we celebrate them and say half their size, how they did it. No surgery, no gimmicks, okay? Now, that's a tagline from People magazine. I think it was 2014, 2013. Maybe you've heard me talk about this before. To People magazine's credit, they no longer have the tagline of no surgery, no gimmicks. But the point being is that we celebrate people who are losing weight through changing their nutrition and increasing their physical activity, and we put them on the cover of People magazine. Now, how do you get to be on the cover of People magazine? Well, you have to be an outlier, okay? Something very unusual has to be present about you. And in this case, it's because we're putting these people on the cover of People magazine as if what they did is so simple, okay? So easy, but it's not. Because the first law of thermodynamics, it only tells us what conditions need to exist in order for weight to change, but it doesn't tell us why those conditions exist. And when we really focus on obesity and why is it that a person might be eating more and exercising less, let's focus on that for a moment, because this is a really important point and where we bump up against the limits of the first law of thermodynamics as it relates to explaining the obesity epidemic. So let's talk. We're going to do a deep dive on the causes of obesity here, okay? Now, you're probably thinking, well, of course, it is the Western diet, our very highly processed diet that is energy dense and carbohydrate dense, right? Whether those carbohydrates are soft and sweet or salty, crunchy. And I can't do this podcast and tell you no. That's not a contributing factor, because I do think that our westernized diet absolutely increases our risk for obesity. If a person's eating highly processed, carbohydrate, calorie-dense foods, they are increasing their risk for developing obesity. But that's not the only picture. So then we have to look at low physical activity, right? I mean, as human beings, we're so darn smart. We are really smart, and arguably we're kind of smart, too smart for our own good, because even though we have developed ways to mechanize our world and simplify it so that we really don't have to be particularly physically active, our genetics hasn't changed a whole lot for thousands of years. So we are still genetically the people that lived in caves. And when we were not walking and foraging for our food, we were running for it. But we're so smart, we've developed ways to mechanize our world so that we don't have to expend a whole lot of energy in order to survive any longer. But that's not all there is to it. So let's look at genetics. I want to ask you, how did you guys do on choosing your parents? Did it go well for you? I mean, okay, I'm not here to pick on parents. Hopefully, every single one of you is thinking, I love my parents and I wouldn't change them for the world. I hope that's the case. But when we look at genetic makeup, there's absolutely a contributing factor of genetics to a person's risk for developing obesity, okay? So you wouldn't want to change your parents for all the world, and you might have inherited a genetic risk for obesity. Now, psychology, okay, that also contributes to obesity, but this one is really tricky Because it's not fair to say that every single person who's affected by obesity has psychological issues. You can't say that. The same way, you can't say that everyone with psychological issues has obesity, right? There's not a direct cause and effect here. But how does it feel to walk around in a body affected by obesity in the way that how the world treats you, right? It can be hard, and that absolutely can affect your psychological fortitude. So this part is tricky, so I need to take us on a tiny little bit of a detour here. And this is absolutely a nod to one of my thought leader mentors, Dr. Brene Brown, because she talks about how as human beings, we are hardwired for connection, right? We are biologically hardwired for connection. But when we don't experience connection, and by connection, we're talking about honest, true, heart-to-heart connection. We all know it when we're experiencing it. And we know it when we don't have it. And I'm not talking about connection, or we could call it pseudo-connection, like you comparing your bad hair day to somebody's good hair day on Facebook, okay? You know me, I'm all over Facebook, but I also recognize that it is not a stand-in for real, honest human connection. And when we do not experience regular, ongoing, deep human connection as human beings, we do experience depression, emptiness, anxiety, disengagement, loneliness, isolation, and shame. I call these the 7 deadlies. And these are really painful emotions to experience. Every single one of us has experienced it. It doesn't matter to me whether you've been affected by obesity or not. These are part of the human condition, we could say. And they're so uncomfortable that we seek to treat these painful emotions. And if you can't treat them by forming deep bonds of connection, we often as human beings treat by numbing, right? We numb. And how do we numb? We numb by trying to buy our way out of the painful emotions, eat our way out of the painful emotions, medicate our way out of the painful emotions, and use drugs of abuse to numb our way out of these painful emotions. As a result, Americans today are the most debt-ridden, obese, medicated, and addicted than we've ever been before. So when we talk about psychology and obesity, yeah, I think we can just sum it up and say it's complicated. Now, the social nature of food, that's another cause of obesity, right? We get together, in America, came through Thanksgiving and Christmas and Hanukkah and Kwanzaa and whatever it is that you're celebrating, right? And I'm pretty willing to bet there was food that was being passed between people as forms of celebration. So we connect with food. We also disconnect with food, right? If there's things that you don't want to talk about, well, food becomes the kind of social glue or the commonality that you can share without talking about painful emotions. But we've found ways to celebrate Valentine's Day and birthday and Easter and 4th of July and Halloween and all of these different holidays with food. And I don't think that this is bad, right? Again, we're talking about connection. I don't think that using food as a way to share experiences with people is a bad thing. It's just how much food and what are the foods that we're choosing. Now, portion sizes is another contributor to obesity and also food abundance. You can't watch TV for more than 5 minutes or sit in a movie theater for more than 30 seconds with being bombarded by food cues, whether those are visual food cues or maybe it's the smell of food when you walk into that movie theater, wherever it is. And the portion sizes, 20 years ago, a standard bagel was 3 inches in diameter and was 140 calories. Now today, a standard bagel is 5 to 6 inches in diameter and is 350 calories. A hamburger in 1955 was 3.75 ounces. It's now standard anywhere from 7.5 ounces to 9.2 ounces. And a muffin 20 years ago was 1.5 ounces, where now it's 4 ounces. So we've become adapted to expecting that our portions of whether it's an individual food or a whole meal should be gigantic. And we simply do not need the calorie burden that we are feeding ourselves. Injury and disability is another contributing factor to obesity. I can't tell you how many times I've heard the story, and perhaps as a listener, you're thinking about it right now. Yeah, I was a little overweight and then I blew out my knee. I injured my back at work, etc. Something happened and I was bedridden for a year, and the next thing I knew, I was up 100 pounds or whatever that thing was. I couldn't go to the gym anymore, and I got a little depressed because I've disconnected from my work, and food was there for me. So injury and disability are definitely contributing factors to obesity. Now, medications is another contributing factor. Now, again, we're so smart as human beings. We have the ability to create incredible medications to manage many of the chronic diseases that we are afflicted and affected by as human beings. But one of the common side effects for many medications is weight gain, or if it's not overt weight gain, in the very least, it's resistance to weight loss. So classes of medications, just broadly speaking, that have been implicated and we know are problematic when it comes to weight issues are antidepressants, antipsychotics and mood stabilizer medications, antihypertensives, corticosteroids, seizure medications, and diabetic medications, ironically and unfortunately. Now, please do not hear me say that if you're taking any of those medications to stop taking them. I'm not saying that. I just want you to understand the complexity that comes along with taking medications, okay? But if we could say, you're on insulin for your type 2 diabetes, don't stop taking that because the benefit that you get from those medications outweighs the risk. But just understand that you can't get something for nothing, unfortunately. Now, sleep deprivation, oh boy, is another contributing factor to obesity. And, really, sleep is the unsung hero of health and weight loss. And I have to give a shout out now to CPAP and sleep apnea, because this is something to speak for a moment about Southern Oregon Bariatric Center. We are actually very aggressive in evaluating people for sleep apnea and making sure that they're on CPAP prior to proceeding with bariatric surgery. So, and one of the tools that we use is a tool that you can find online for free. It's been a validated test, and it's called Stop Bang, and that's an acronym, and I won't go through the details, but it's snoring and tired, etc. So a stop bang is considered positive if a person has two or more of the following. And just briefly, if they snore loudly, if they're tired, fatigued, or sleepy during the day, if someone has observed you stopping breathing or stop breathing while you're sleeping, or choking when you sleep, if you have high blood pressure, if your BMI is greater than 35, if your age is greater than 50, if your neck circumference is greater than 17 inches for a man and 16 inches for a woman, and male gender in and of itself increases the risk for a person having obstructive sleep apnea. Now, if you just heard me rattle off that list and thought, oh gosh, yeah, I snore and I'm tired all the time and I have high blood pressure and my BMI is greater than 35, and you've never been evaluated for obstructive sleep apnea, then my strong recommendation is that you get evaluated, and if you need CPAP therapy, that you get on CPAP therapy. In our program, we are aggressive with this, and I would say, just a rough estimate, 60% of the patients that come to us have never been tested for sleep apnea. We send them for testing, and of those 60%, I'd say probably greater than 50% of them are positive for moderate to significant or severe obstructive sleep apnea. So my general opinion is that this is a significant problem for people affected by obesity, and it is being not only underdiagnosed, but not only undertreated, but underdiagnosed. Okay. So do yourself a favor and get on CPAP therapy if that's something that your body needs. Your body will thank you for it. Okay. Stress. That's another cause of obesity or contributing factor to obesity. I probably just stressed you out a little bit talking about all these things and CPAP. Maybe you're thinking, oh gosh, I was tested 5 years ago and I'm supposed to be on CPAP and I never use it. And now I'm stressing you out. Okay, that's not my intent. I'm really here to care. But stress is absolutely a contributing factor. And on my PowerPoint, if you're not watching it right now, I have one of those little images that says stressed is desserts spelled backwards. And joking aside, right, when our brain is stressed and needing relief and it can't get the relief, what does it do? It seeks out really simple carbohydrates, whether for you that's going to be a chocolate cake, as this woman is holding in the cartoon that I have pulled up here, or maybe it's salty crunchy. If you know what I'm talking about, you know what your go-to food is when you're stressed, okay? Now, bacteria, another contributing factor to obesity. And by this, I specifically mean bacteria in the gut, also known as the gut microbiome. And the science of this is catching up to obesity rates, which means we don't yet have a pill that has good bacteria in it that a person can take and reset the flora of their gut and reduce their tendency to hold on to excess adipose tissue or fat mass. But the science is really interesting and pointing to that bacteria in our gut does play a role in whether a person is going to be absorbing extra nutrients into their bloodstream or not. And some of the science is saying that people that are affected by obesity have microbes in their gut that are breaking nutrients down into smaller and smaller and smaller pieces, and thus making it more easy for those nutrients to be absorbed into the bloodstream. Once it's in the bloodstream, your body has to deal with it. It's either going to store it as energy in your muscles, or it's going to store it as energy in your fat mass, or your brain's going to use it right away. But in any case, your body has to deal with it. And some bacteria are seeming like they increase a person's risk for nutrient absorption. So stay tuned on that. And I will say that for me, that does kind of beg an interesting and important question, which we've not answered, but is there any element of obesity that could be considered a communicable disease? Whereas, if it's apparent to a child, it's not necessarily the food that the parent is feeding to the child, but maybe it's the hugs and the kisses and the sharing of bathrooms and just sharing of general bacteria that we all share with the people that we live in a home with. So I don't know. Stay tuned. Now, my final little cause or contributing factor to obesity here is hormonal imbalances. And this is a pretty big topic. Now, hormonal imbalances, the obvious is going to be thyroid issues or low testosterone. Maybe it's going to be menopause, or maybe it was puberty, or maybe it was pregnancy. Lots of women that I talk to say, well, they gained 75 pounds during their pregnancy, and despite how much they breastfed or walked afterwards, they were never able to lose that weight. So there's a lot of different hormonal imbalances that can contribute to obesity, but I really want to focus on the hormonal imbalances that happen directly related to holding on to adipose tissue, hormones that are released from fat mass and also the guts. Because when we start looking at, our People magazine folks and we say, well, these people are half their size, it really begs the question of how did they do it? Okay. And will it last? And if it won't last, why not? And this is where we have to this is where we have to dive into gut hormones and why bariatric surgery is different than going on another diet. Okay. Because if the first law of thermodynamics tells us that you lose weight when you eat less and exercise more, why do we fail to lose weight to begin with? Or why do we fail to keep the weight off? Now, okay, I want you to picture a bathtub because I want to try and answer this question. Okay, you're picturing a bathtub, right? And the water that's entering into the bathtub, that is your energy in. That's food that you're eating. Okay, so energy's entering into the bathtub and the water level is filling up inside the bathtub. Now, the drain is also open on the bathtub and water is leaving. That's energy out. That's your metabolism. That's physical activity. Okay. Now, where the water level settles when the amount of energy that's going in is equal to the amount of energy that's going out, we call that the set point. If you've listened to my episodes before with Dr. Randy Seeley, we've talked about set point. And quick little disclaimer, set point is not set, but for the sake of this argument, meaning set point increases over time. But for the sake of this argument, we're going to talk about set point as if it's sort of a static thing, but please keep in mind that it isn't. And I have to give credit here to Dr. Randy Seeley, because when it comes to talking about set point within the bathtub analogy, the credit goes to him because he's the one that helped me understand it with this. And I have a simple brain, so I got to kind of explain things to myself simply, and you guys get caught up in that. So I hope you appreciate it or not. Okay, moving right along. So set point, and this is according to the science of doctors Seeley and Lee Kaplan. Okay. Set point is defined as your body's defensible weight, and it's really not weight. Your body doesn't care about weight. As Dr. Randy Seeley likes to say, you don't have scales on your feet communicating to your brain and your gut saying, oh, well, we're down 5 pounds or we're up 5 pounds. No, your body doesn't care about weight. Your body defends adipose tissue. Adipose tissue is your fat. Okay. Set point for fat mass is determined by biological signals that regulate both food intake and energy expenditure. Food intake and energy expenditure. Similar to, I could say to you, hold your breath right now. And you could hold it for a minute, maybe 2 minutes. Maybe some of you could even hold your breath for 3 minutes. But eventually, you would start breathing again because your biology would win out. Right? You don't have conscious control of your breathing, and you don't have conscious control of the temperature within your body. Well, set point basically tells us we do not have conscious control of our weight. It is not under thought control. It is determined by gut hormones, fat hormones, and the deep central nervous system of the brain, specifically the arcuate nucleus within the hypothalamus. Okay. We can't think our way around that and determine what your gut hormones, fat hormones, and hypothalamus are going to be doing. Okay. These are biological signals there to maintain a status quo, whether you consciously like it or not. Okay. So a person who's affected by obesity, we could say their set point is elevated. And just to work with round numbers, maybe it's 100 pounds over what would be ideal for that person. Okay. And 100 pounds over, they have obesity and they have the associated diseases. Well, they say, well, I don't want that. I want to lower my weight. So how do they do it? Well, first law of thermodynamics, you eat less and you move more. Okay. And as we know from the people on Cover magazine, the people on the cover of People magazine, you can drive down your weight, right? You can do it. But what about your set point? Okay. If your set point is going to be 300 pounds and you drive your weight down to 200 pounds, what happens to that biology that's saying, no, our set point is 300 pounds? Well, the reality is biology fights back. It fights back fiercely. During and after weight loss, and this is non-surgical weight loss, leptin levels decline. And leptin is a hormone that drives satiety. So satiety, your satisfaction with a meal, goes down. Amylin, GLP-1, CCK, glucagon, and PYY levels, these are gut hormones, all decline. As a result, hunger goes up, cravings go up, satiety again goes down. Ghrelin levels, and ghrelin does basically what it sounds like, grrr. Ghrelin levels increase, so increase hunger. Fat oxidation goes down, so burning of fat goes down, and metabolic rate goes down. So And just to wrap that up one more time, hunger and cravings increase, hormones that drive satisfaction go down, fat burning decreases, metabolic rate decreases. So the first law of thermodynamics here is where we get our why for regain. We regain weight because of powerful biological forces that are driving us to eat and a slower metabolic rate that goes down, and this is known in scientific literature and talk as metabolic adaptation. Your metabolism slows down. So biology wins out. Now, I don't know if you saw the article that came out in the New York Times in May of 2016, just last year, and it was titled, "After, quote, the Biggest Loser, Their Bodies Fought to Regain Weight." So this New York Times article was a great article, and it was talking about a study that was done by Frothgill and colleagues, where they studied 14 of the 16 participants from season 8 of the very popular TV show, The Biggest Loser. They studied them at the beginning of The Biggest Loser, and they monitored them for 6 years afterwards. Okay. Now, the average weight regain over those 6 years was of the weight that people lost during I think it was 12 weeks of The Biggest Loser. 6 years later, they on average had regained 71% of their lost weight. Okay. Now, when they looked at metabolism, and they looked at the beginning of the season to the end of the season, so beginning to 12 weeks later, their metabolism had declined 610 fewer, they were burning 610 fewer calories per day. Okay. Now, 6 years later, the majority of the contestants had regained some, if not all of their weight. And you would think they're regaining their weight, their metabolism is going to respond as well, right? Because you regain weight, you regain fat mass, arguably you're going to regain some muscle mass too, and muscle equals metabolism. Muscle equals metabolism. Okay, so you'd think that their metabolism would correspondingly go up, but it didn't. Their metabolism was lower 6 years later than it had been at the conclusion of the 12 weeks of The Biggest Loser contest. So they concluded the 12 weeks burning 610 fewer calories. At the end of 6 years, that 610 was now 704 fewer calories per day, okay, despite their weight regain. So now they're gaining weight, and in order to stop the weight regain, I mean, they'd have to drop their calories down even further. And what do you think their biology is going to do, right? It's going to drive them to eat. It's going to make them hungry. So very, very frustrating for people to hear that. Now, of the 14 contestants, it looks like 4 of them 6 years later had increased their weight beyond what their weight was even before they started The Biggest Loser. Only one contestant 6 years later, only one of the 14, her weight was down from where she ended the 12 weeks, and that was Erin Egbert. Danny Cahill, who won the contest by losing 239 pounds, 6 years later was up 100 pounds. Okay. Now, another contestant, Rudy Paul, who was in second place behind Danny Cahill, also started rapidly regaining weight. And it looks like at about 4 years, I'm looking at a bar graph here, or a point graph, something changed. His line is going up and up and up, and then there's a point and it starts dropping in the other direction. Well, what do you think he did? He had bariatric surgery. Okay. It says Rudy Paul's regained 80% of his lost weight, then had surgery to reduce the size of his stomach. Now, we don't know from that little descriptor whether he had Roux-en-Y gastric bypass or gastric sleeve, because it could be either one, both reduce the size of the stomach. But needless to say, he was on a rapid weight regain trajectory. Then he had bariatric surgery. So, enter bariatric surgery. We're 39 minutes in here, and now I'm going to start talking to you about bariatric surgery. because it's different. It's different than going on another diet. So more than a decade ago, the National Institutes of Health did recognize that bariatric surgery, and I know this podcast is called the Weight Loss Surgery Podcast, but really I do like to refer to bariatric surgery as its technical term, bariatric surgery. And that's because I can guarantee, I don't even need to know any of your stories to know that you are considering bariatric surgery for more reasons than just changing your weight. And when we call it weight loss surgery, we're really just highlighting one metric of why it is you're seeking to do this. And weight is going to be part of that, but it's also going to be maybe you don't want to go on insulin and that's the next step, or, you're tired of all the pills you have to take, or you've seen that orthopedic surgeon and they've said, well, yeah, I'll replace your knee after you lose 100 pounds. Don't mean to pick on orthopedic surgeons. I've just heard that line so many times. It gets kind of frustrating because then they don't necessarily offer solutions or even refer people to see us. Or, maybe it's a quality of life issue. You want to be able to go to an amusement park and not have to worry if you're going to get called out because of a weight limit. Or you want to be able to go on the plane and not ask for the seatbelt extender. Or you want to be able to go to a restaurant and not have to share and table map and wonder, oh God, don't sit us at a booth because I'm not going to fit. Or, oh gosh, will those chairs hold me? Maybe you want to cross your legs for the first time, or you want to hold your grandchild on your lap, or you want to be able to tie your own shoelaces or paint your toenails, like you pick, right? You're interested in bariatric surgery for many more reasons than just changing the one metric of weight. So, okay, back to the National Institutes of Health. They did recognize that bariatric surgery is the only effective treatment to combat severe obesity and maintain weight loss in the long term. Okay. Now, why is bariatric surgery different than going on another diet? Because rather than lowering weight alone, bariatric surgery, here's a kind of a spoiler alert, but I guess it's time that I get to it. Bariatric surgery lowers your set point. Okay. Makes it easier for you to defend a lower weight. And by easier, I mean biologically easier. Okay. It's not necessarily a willpower thing, although willpower, factors into it. You got to be committed. You got to be all in, or as one of my patients said, there's no play in my game, Rieger. I love that sentence. But bariatric surgery resets your set point. Okay. So when we go back to the bathtub analogy, just picture that the water level goes lower. And in order to support that, you're eating less because you're biologically driven to eat less, and your metabolism may or may not increase, stay the same, or decrease, but the drop is nowhere near as significant as with diet alone. Okay. Like the Biggest Loser folks whose metabolism dropped. The studies are showing that bariatric surgery, if it affects metabolism, it's nowhere near as drastic of a drop. And the rebound is not as significant of going up. And the diseases, therefore, that are associated with obesity also improve significantly. And we could certainly argue that you're losing weight, you're feeling better, you're more prone to going to the gym, going for the walks, getting your exercise, and burning more calories consequently. So when we talk about gut hormones as they pertain to the stapling surgeries, so that's going to be Roux-en-Y gastric bypass, which I'm going to dive into here next, and gastric sleeve. The stapling surgeries, something about manipulating the stomach in the case of both surgeries and the small intestine in the case of Roux-en-Y gastric bypass, results in increased leptin levels, or at least increased sensitivity to leptin. And leptin is a hormone that drives satisfaction or satiety. So satiety goes up. GLP-1, PYY, CCK, glucagon, and amylin levels all increase, which results in decreased hunger, decreased cravings, increased satisfaction. Ghrelin levels decrease, so that's hunger. Hunger goes down, and fat oxidation goes up. so burning more fat. Now let's talk about your surgical options. So as I already mentioned, I'm going to focus on Roux-en-Y gastric bypass and sleeve gastrectomy. Okay. Now, Roux-en-Y can be a confusing surgery for people to understand what's done, and we have a lot of different names for it. It's RNY, RYGB, bypass, gastric bypass, or its formal name, Roux-en-Y gastric bypass. It's all the same surgery. And what happens in that case is the surgeon divides the stomach very high up and creates what we call a pouch that's approximately the size of a chicken egg. Okay. So you have a new stomach known as a gastric pouch. Okay. And then the surgeon follows the small intestine down to where the small bowel transitions from the first part, which is known as the duodenum or duodenum, and the jejunum is the middle section. So the surgeon divides that part of the small bowel in half. The lower section, the jejunal section, jejunum, the surgeon brings up and staple connects up to the gastric pouch, the new stomach. Okay. So what that does is you now have a smaller stomach with a shortened digestive food channel, basically. And so then if you're paying attention, you must be, well, what happens to the stomach, my old stomach, and what happens to the duodenum that was disconnected? Well, the duodenum or duodenum is connected back into the jejunum. Okay. So that creates kind of the Y, that creates the Y of Roux-en-Y gastric bypass. And let's talk about the stomach, the old stomach, which now we call the remnant stomach. People wonder, well, why is it left in the abdominal cavity? And if it's not connected to food that's entering into my body, why leave the old stomach in there or the remnant stomach? And there's some very sound reasons why the remnant stomach is left in, and that's because it still creates or secretes gastric juices for digestion, those acidy juices that help us digest our food. Then right below that is where pancreatic enzymes, which are also digestive enzymes, also enter into the small bowel. And at that same spot, it's where bile enters into the small bowel. So gastric juices, pancreatic juices, and bile juices. And it doesn't matter if you have a gallbladder or not, because your liver's still making bile and it's still entering into your small bowel. Those juices are still being created and they still flow down the duodenum and enter into the jejunum where the new opening was created. And it's really from that point down that we consider the majority of nutrient absorption occurs. And that point down, we call that the common channel. Okay. So that's kind of I hope that made sense. That's, there's pictures. If you go to to the YouTube channel, you can see the pictures of Roux-en-Y. You could also go to, wherever, just Google Roux-en-Y gastric bypass, and you'll see the anatomy of what it is that I'm talking about. Now, what are the advantages of gastric bypass? It does produce significant long-term weight loss in the realm of 70% excess weight. So what do I mean by 70% excess weight? Again, let's pick the 100 pounds. If you're somebody that would benefit from losing 100 pounds of weight, you could anticipate losing 70 pounds of that 100 pounds through having gastric bypass. It does restrict the amount of food that can be eaten. Remember, you've got that small new stomach, the pouch, may lead to conditions that increase energy burned. This is the science that I'm talking about, where we're starting to understand that these stapling procedures are not just about restriction and malabsorption, but they really are metabolic surgeries that alter our metabolism, how we are utilizing energy. They do produce favorable changes in gut hormones that reduce appetite, hunger, and increase satiety, fullness. We've been talking about that. Now, typical weight maintenance with gastric bypass is in the realm of greater than 50% of excess weight. So I started out by talking about the advantages of gastric bypass by saying it's 70%. You could expect to lose 70%, but now I'm saying, well, it's actually 50%. Why the discrepancy? And that's really because gastric bypass has been around the longest, 30 plus years. So it's been studied the most. And then as human beings, we're going on with our lives, and the people that had gastric bypass 25 years ago are going on with their lives. We can expect a bounce in weight going upward, right? We are energy storing machines as human beings. And so a person who had gastric bypass 25 years ago, they could expect to have a little bit of weight regain over their lifetime. Now, we could also argue that they are living longer, right? Maybe they are not dying earlier of a cardiac disease or stroke or whatever. And so they're going to have a little bit of a bounce in that weight. That doesn't necessarily mean that their diabetes is going to come back. Doesn't mean that their heart disease is going to ever present. Okay. So there's still a tremendous amount of benefit to be had from losing 70% of your excess weight. I mean, wouldn't you like to know that you could do that and keep that weight off for the rest of your life? I think that sounds great. It is now the second most commonly performed surgery in the United States, but it has been around the longest. Okay, so let's talk about disadvantages of gastric bypass. It's a technically more complex operation than sleeve gastrectomy and potentially could result in greater complication rates. It can lead to long-term vitamin and mineral deficiencies. Okay, that's a disadvantage, but we got to get this one out of the way right now. Let's just do it. Okay, if you are somebody that's going to have bariatric surgery at any point in your future, you have to promise me right now, and I'm listening, I want you to say it out loud, that you're going to take your vitamins and minerals, your vitamins as prescribed, as recommended every day for life after surgery. If you do that, I promise you, you have a very low risk for vitamin deficiency. If you don't do that, you have a high risk for vitamin deficiency. And I don't want to make this too complicated, right? Because people think, oh my God, the vitamins, it's going to be this, like I'm going to have spreadsheets and algorithms and I'm going to have to understand nutritional science. No, you don't. Generally speaking, it's going to be one multivitamin 1, 2, or 3 times a day, depending on the vitamin. And that vitamin should have, you know what? I'm not going to go into the specifics of what it had. It's on my website, Ask Your Bariatric Surgery Program. So a multivitamin and as well calcium. Now that I can tell you it should be calcium citrate, and you want to take in general 1,500 milligrams of calcium citrate daily. Okay, do that, you're golden. Okay. Now gastric bypass in general has a longer hospital stay than gastric sleeve or lap band. And at our program, it's generally 2 nights instead of 1. Okay. Another disadvantage of gastric bypass, which this is, just standard stuff, requires adherence to dietary recommendations, lifelong vitamin and mineral supplementation. We've already gone over that, and follow-up compliance, right? You got to work your program. Why would you do this anyway? To not eat properly, get regular physical activity, take your vitamins, drink your water, and go for follow-up, right? You're not going to do all of this and then just drop the ball. I trust that. Okay, so let's talk about the next most common, or now the most common bariatric surgery, at least in the United States, and that's vertical sleeve gastrectomy, also known as the sleeve. And the sleeve is basically a surgery where the surgeon comes and divides the stomach in half following what we call the greater curvature of the stomach. And approximately 3/4 of the stomach is removed from the abdominal cavity. With vertical sleeve gastrectomy, or the sleeve, there's nothing implanted. There's no sleeve that's left inside the new stomach. It's just the new shape and size of the stomach that was just sort of, I don't know who decided to call it the sleeve, but that's just kind of what it's called. So nothing is implanted or left inside the abdomen, outside of the stomach or inside the stomach. Okay. It's just the shape of the stomach is changed in and of itself. Now that 3/4 of the stomach is surgically removed. The small intestine, where I was just talking about the duodenum and the jejunum, that's not touched with sleeve. Okay. The small intestine is left untouched. Now, advantages of the gastric sleeve. It is a less complicated surgery to perform than gastric bypass, right? It does have the lowest reoperation rate of all bariatric surgeries. It does restrict the amount of food that can be eaten because now you've got, the way we talk about Roux-en-Y as creating a pouch stomach that's about the size of a chicken egg. Generally, we talk about the sleeve as if it's like the shape of a standard banana, okay? It does induce rapid and significant weight loss comparable to Roux-en-Y gastric bypass. Okay, comparable. So that's 70% excess weight loss, comparable with the sleeve. And I would say with the patients that I follow up in the office, that particularly for the first year, that is very true. Okay, I need to remember whether this person that I'm seeing had sleeve or Roux-en-Y in order to when I'm looking at their weight, because their weight loss is parallel to each other. I will say that at about, 12 months, 18 months, 24 months, on average, Roux-en-Y gastric bypass in our program has outpaced people that have had sleeve in weight loss by the average is 20 pounds. Okay. So now it's hard to talk about averages because we operate on adults only 18 and older. And so it's hard to draw an average when you're talking about a 25-year-old male who might have had sleeve gastrectomy and a 66-year-old female who might have had Roux-en-Y and said, okay, let's compare their weight loss, because there's sort of apples and oranges. But in general, between both procedures, all ages and both genders, at our program, Roux-en-Y gastric bypass loses about 20 pounds more. Okay. Now, another advantage of the sleeve, there's no bypassing or rerouting of the food stream, like in Roux-en-Y gastric bypass. I just mentioned that. And it is now the most commonly performed bariatric surgery in the United States. I'm not sure about worldwide, but I suspect in places like, Australia, New Zealand, Europe, Mexico, that this is also true. And I didn't take the time prior to hitting play or record to look that up, but that's my suspicion, is that sleeve is now the most common bariatric surgery in the world. Disadvantages of the sleeve. It's not reversible, right? So that part of your stomach that's removed, it's removed from the abdominal cavity. Now, perhaps you're thinking, oh, well, I didn't think about reversibility. Maybe Roux-en-Y gastric bypass is reversible because nothing is removed from the abdominal cavity. Well, I'm here to tell you, don't ever go into Roux-en-Y gastric bypass thinking, well, if it doesn't work out, I'll just reverse it, because that is not a surgery you ever want to have to reverse, right? It's really only considered in kind of life-saving measures, generally speaking. If somebody's having significant issues related to Roux-en-Y gastric bypass, it might be reversed. And I'm also here to tell you, statistically speaking, that happens very, very, very rarely. Okay. So, and you're not going into bariatric surgery thinking, well, if it doesn't work out, I'll just go backwards. What was the quote that I saw today? Your windshield is larger than your rearview mirror because your future is bigger than your past. I don't know. Maybe that kind of applies here, but I liked that quote. Okay. So another disadvantage of the sleeve, it has the potential for long-term vitamin deficiencies, but we've already addressed that and you're going to take your vitamins. And it could possibly increase the risk for gastric reflux or gastroesophageal reflux disease. The jury's kind of out on this, but for us at our program, this does give us pause a little bit. If we have somebody who has chronic gastroesophageal reflux disease and they are considering gastric sleeve, we do send them for upper endoscopy, for that camera to go down their esophagus and look at the lower end of their esophagus and upper part of their stomach, to see how healthy is that tissue. Because if a person is already suffering from the ill effects of chronic reflux, and maybe they have what's called esophagitis or Barrett's esophagitis, we might want to pause a little bit before proceeding with gastric sleeve, because there is some data that's pointing that it could increase gastric reflux, ergo making esophagitis worse. Okay. And Barrett's esophagitis is a precursor for esophageal cancer. So you kind of have to take that seriously. Okay. So now let's talk about the general risks of bariatric surgery, just in general, regardless of the procedure that you're going to have. And, side note, I do kind of feel badly that I'm leaving off lap band. I am a believer in the lap band for a select group of people. I do think that the lap band, gastric adjustable banding is technically how it's called, is a very good tool for the right person at the right time in their life. Well, that's true for all bariatric surgeries. So in any case, I don't mean to diss the band at all, in the fact that I'm not talking about it here. It's just time. And I think listener interest is definitely going to be more focused on Roux-en-Y gastric bypass and gastric sleeve. I've talked a lot about gastric band in prior episodes, and all of those episodes are still, all that data, everything that I talked about is still absolutely current to today. Okay. So general risks of bariatric surgery, vitamin and mineral deficiencies, we've already addressed that. Chronic nausea. Yeah, it can happen to a small subset of people. Chronic abdominal pain, small subset. Constipation, excess gas. Oh, yeah. And we're talking about stinky farts, basically, is really what we're talking about here. Just a side note, there is an over-the-counter product called Devrom, Devrom, which is a flatus anti-deodorant. Hey, who knew? But you can get Devron at a pharmacy near you, and if you can't do that, you can get it on Amazon, and it's not very expensive, and it works quite well. Okay, I mean, we're not talking like roses here, but we're talking like your family is not going to be afraid to get in the car with you kind of thing. And that's a win, right? Okay, gallstones, increased risk for gallstones with rapid weight loss, and that's if you still have a gallbladder. Excess skin. Yeah, okay. Excess skin is a reality after significant weight loss. And the fact of the matter is that the majority of insurance policies are not going to pay for skin removal surgery. Even depending, you hear about, well, you could maybe donate your skin to skin burn units. I think that's medical urban legend. I've never been able to substantiate that. People will say, well, your insurance policy will pay for it if you have skin rashes in between your skin folds. Very hard to get approved. I will say squeaky wheel gets the lube here. So, if you appeal and appeal and appeal, you quite possibly could win that appeal and have your insurance pay for excess skin removal. So, in part, I kind of think of excess skin is a little, and this is something that one of my patients told me, it's her price for admission. It's the tax she pays in order to have the new life that she has. And it's a price that she's very willing to pay. And I will also tell you that I have never met a single successful weight loss maintainer after bariatric surgery who also has excess skin who tells me they would rather trade their current life for their past life where they had excess adipose tissue, excess body fat, for their current life where they have excess skin. So there you go. Temporary hair thinning is another risk for general risk for bariatric surgery. Now, this is not chemotherapy bald. Okay. This is temporary hair thinning that peaks at about 6 months from the date of surgery. Okay. Some patients like to take biotin. I'm not against that in and of itself. I don't think that it hurts. Whether it helps, I'm honestly not sure. So I leave that up to you. Just know that the hair loss is temporary, and it's most commonly when I walk in that room at 6 months, it's not so socially significant that I walk in and notice it right away. But the person often who's experiencing it feels like, oh my God, when is this going to stop? And when I see them at their 12-month visit, it's stopped. If it hasn't stopped at that point, then I'm worried nutritionally what's going on. And I'm getting more vitamin levels, and I'm talking to this person about their nutrition and what's, kind of doing a little bit more in-depth deep dive on what might be causing that. And we also do have to factor in hereditary pattern baldness, whether you're male or female. I definitely have some females who have a family history of female pattern baldness, and the hair that they lost in the process of weight loss related to bariatric surgery, sometimes those hair follicles don't turn back on. And if you want to look up hair thinning related to bariatric surgery, technically it's known as telogen effluvium. telogen effluvium. Okay. So other general risks for bariatric surgery is a change in the taste of food. So this happens really quickly, and maybe it's because of the ketosis that happens, or maybe it's just the general hormones, or maybe it's that you're trying new foods and getting off your soda or getting off whatever it is that you thought you couldn't live without, if that applies to you. That's not true for everybody. But a change in taste of foods happens really quickly for people. And sometimes it can be a really great thing, where a person thought, oh my God, I didn't think I could live without soda. And I had a little tiny sip the other day and oh my God, I spit it out. It tasted disgusting. How did I ever like that? But sometimes the change in taste of food can be a negative for a person. Maybe they bought a whole bunch of a particular protein drink, and they thought this was going to be their thing to carry them through. And then they're 6 weeks out and from surgery, and they can't stand the taste of that protein drink. Often it's that hypersweetness. All of a sudden, your tongue becomes really sensitive to it. Also, people can develop a hyper sense of smell. That usually calms down. But when people tell me, oh my God, I can smell butter from across the room, what is up with that? Yeah, that's just part of the changes. I can just chalk it up to hormonal changes. I don't really know why it happens. I just know it's really common. So my advice to people who are experiencing this is understand that this is quite normal, and your food preferences and texture preferences are going to be a moving target for the first 3 to 6 months after bariatric surgery. So be adaptable, be flexible. You thought the cottage cheese was going to be your thing and now you can't stand it. Okay, move on. Next. Be willing to experiment. Another general risk for all bariatric surgeries, some to all weight regain. Yes, it can happen. Okay. It can happen for a complicated milieu of reasons. I've talked about this on prior episodes. In general, I'm going to say that one of the more common reasons why some to all weight regain can happen is because people stop working their program. They stop following the nutrition guidelines, getting the regular physical activity, going to support group, coming in for follow-up. So I can honestly say I have never met a single weight loss maintainer who doesn't follow their program. And their program is a version of whatever they got from their bariatric surgery practice, but it's theirs, and they know when they're on it and they know when they're off it. So, okay, I've talked about this before. Transfer addiction, that's also a risk after bariatric surgery. I was talking earlier in this podcast right today about numbing behaviors, right? How we seek to numb if we are dealing with uncomfortable emotions. Well, people can be addicted to food or use food to medicate their emotions. We then do bariatric surgery on them. If they're not really finding other ways, healthier ways to deal with those emotions, they are at high risk for transferring their numbing addiction to food to something else. What could it be? Well, anything a human being can become addicted to. Cigarettes, alcohol, drugs. Those are the top 3. Okay. Shopping, online shopping, gambling, pornography, whatever it is. If a human being can become addicted to it and it's maladaptive, that it can happen after bariatric surgery. Okay. And by maladaptive, I mean, if it's a problem, right? So sometimes people will say, well, she transfer addicted to exercise or he transfer addicted to exercise. Well, is it a problem? Is it, is it ruining their family? Are they not able to function at their job? Are they utterly obsessed with, they've got to exercise? I've seen that happen for people, but it's pretty rare. And so, we have to be careful when we're passing judgment on people, and it's really up to the individual to decide if it's a problem, then it's a problem. So strain on personal relationships. Yes, having bariatric surgery can place a strain on personal relationships, whether that's your spouse, whether that's your children, whether that's your parents, whether that's your colleagues at work, whether that's an acquaintance who barely knows you. Maybe you see them at church. They don't know your personal story and you start losing weight. You haven't told them your story because nod to Brene Brown. Those people haven't earned the right to hear your story. I really think that people have to earn the right to hear your story. And they want to know, what are you doing? And you feel like, I've heard this person shame people that have had bariatric surgery before, so I'm not going to tell them. Well, these things can create strains on personal relationships. I had a married couple that that both had bariatric surgery through our program, and they walked the journey together. They changed their nutrition together. They exercised together. They went to support group together. Now, let's just imagine that one of them didn't want to make the changes, whether they had bariatric surgery or not. Do you think that would have put a strain on their personal relationship? You better believe it. Okay. So this can be a case of, if it's an intimate relationship, getting into some counseling, doing some talk therapy with that person, or even alone by yourself to talk through these emotions. If it's somebody who's maybe on the periphery of your life, well, I don't know. I mean, are we meant to have all the people in our lives from day one follow us through? I mean, maybe it's time to kind of step away from that relationship. Okay, so let's talk about general risks of any surgery, whether that's bariatric surgery or gallbladder or whatever. General risks for any surgery include allergic reactions to the medicines and anesthetic complications at the time of surgery, bleeding, chronic pain, blood clots, heart attack, stroke, infection, injury to surrounding tissue, a need for repeat surgery, and death, right? That's a risk for any surgery. So now let's focus in on the general risks of bariatric surgery as they relate to complications and what we call morbidity and mortality. So I'm going to turn to the Journal of American Medical Association, commonly known as JAMA. In 2014, they published a article or study titled "The Effectiveness and Risk of Bariatric Surgery: An Updated Systemic Review and Meta-Analysis." They looked at the years 2003 to 2012, so a long time period. They reviewed 164 studies, which included a total of 161,756 patients, so 162,000 patients. The average BMI of this population was 46. The average age was 45. Now, of all of these 162,000 patients that had bariatric surgery in those years, there was a reoperation rate of 7%. There was a total complication rate of 17%. So 17% of that 162,000 people had a complication. And by complication, we're kind of teasing that out. I mean, yes, a complication could require reoperation, but not always. But if somebody's going to have a reoperation, it's considered a complication. Okay. So total complication rate, and remember, not all complications require reoperations. So total complication rate, which includes wound infections, blood clots, bleeding, etc., was 17%. Okay. Now, the big scary death, mortality rate within 30 days from the date of surgery was 0.08%. So mortality within 30 days from the date of surgery. And if a person is going to have complications that result in death, it's generally going to happen in the first 30 days, 0.08%, which is less than gallbladder surgery and hip surgery, two surgeries that are done all the time, every single day around the world. So when we look at the BMI loss from 5 years, so of the people that they studied at 5 years post-surgery, the BMI loss was down 12 to 17 points. So, in other words, if we took the average 15 points, a person with a BMI of 46, 5 years after their surgery, on average, would have a BMI of 31. Okay. Still technically in an obese category, but significantly better than a BMI of 46. We're talking life-altering quantity and quality of life. They went on to summarize and say that gastric bypass was more effective in weight loss, but associated with more complications. Adjustable gastric banding had lower mortality and complication rates, yet the reoperation rate was higher and weight loss was less substantial than gastric bypass. Sleeve gastrectomy appeared to be more effective in weight loss than adjustable gastric banding and was comparable with gastric bypass. Okay. Now, obviously, it's not just about the weight, right? When we talk about diseases that impact a person's both quantity of life and quality of life, we see benefits in either remission or improvement of type 2 diabetes, high cholesterol, high blood pressure, heart disease, migraines, depression, asthma, heartburn, PCOS, which is polycystic ovarian syndrome. If you're a female affected by it, you know exactly what I'm talking about. Sleep apnea, fatty liver disease, urinary incontinence, arthritis, venous stasis disease, so that's ulcers on the lower legs, and chronic pain. All those things improve with after bariatric surgery. Now, let's talk about candidates who could qualify for having bariatric surgery. In the United States of America, bariatric surgery programs follow the National Institutes of Health guidelines. And a lot of programs in Mexico also follow the NIH guidelines, but I'm much more knowledgeable about what happens within the United States of America. And that could be a question if you're having bariatric surgery elsewhere. Are they following the National Institutes of Health guidelines as just a foundational criteria for who they're accepting as patients? So the NIH stated that candidates for bariatric surgery should have a BMI of greater than 35 with 2 diseases associated with their obesity. So that would be diabetes, high blood pressure, sleep apnea, osteoarthritis, etc. 2 diseases associated with their obesity, or a BMI greater than 40 with no associated diseases. Okay. Now, if you caught me saying, right, obesity is, when we talk about BMI, is a BMI of 30 or greater, but I just stated that the NIH says you're a candidate for bariatric surgery if your BMI is 35 or greater. Well, what about the person who has a BMI of 34 and diseases associated? Could they qualify? Well, as it stands right now in the United States of America, not necessarily. This is a huge debate, and I am in favor of dropping the BMI category to encompass all people, all BMIs within the obese category, so 30 and greater. So stay tuned for that. Okay, so additional criteria would be a person who's unable to lose weight or keep that weight off through non-surgical methods, a person who's able to understand their surgical options, benefits, and risks, right? Able to understand those things. I just went backwards and I didn't mean to. Understand that their eating and physical activity patterns will need to change after surgery, right? I mean, you're not doing this to eat the same way you were before, right? And not get your physical activity and not work on your head and your heart. You're engaged, right? No play in your game. Lifetime follow-up with your bariatric surgery program or a provider knowledgeable in bariatric surgery care. Okay. And you sound like a broken record here. Lifelong vitamin and mineral supplementation. Got to take your vitamins. Okay. Also able to tolerate general anesthesia. Okay. So these are additional thoughts and criteria. This is kind of going a little bit above and beyond the NIH, but I don't think that they would disagree with these next things that I'm going to mention. So able to tolerate general anesthesia, not an active substance abuser. So this is up to each individual program. At our program, you need to be substance-free, so clean and sober, for 2 years in order to consider having bariatric surgery. You have to be in recovery for 2 years. And, when you think about the risk for transfer addiction, if you already are at risk, then that kind of makes sense. If you have psychiatric disorders, they need to be controlled and professionally managed. Okay. No nicotine. Our program is for 3 months. Other programs have different, that's for 3 months before surgery. Sorry, I jumped ahead. Other programs, it might be 2 weeks. It's up to each individual program, but But for us, we say 3 months because we feel like that really gives people time to kind of practice these new skills of what's going to happen when they have a craving for nicotine. And how are they going to work their way around that obstacle without reaching for that substance of abuse? And it doesn't matter, in my humble opinion, it doesn't matter whether you're smoking your cigarettes, e-vaping with nicotine, patching, chewing, however you're getting nicotine into your bloodstream. You shouldn't have nicotine in your bloodstream prior to surgery and for life after surgery. Okay. Nicotine causes vasoconstriction. So that's narrowing of the arteries, your arteries that require that blood passes through, that support tissue, for tissue life. And if you're narrowing those arteries when you have a scar line in your stomach or your small intestine, you already have narrowed arteries, microscopic arteries there. So why increase the risk that you could potentially develop tissue breakdown and ulceration? Okay, so take that very seriously. And also, as I've mentioned, if you are sleep apnea positive, that you're on CPAP therapy. Each individual program is going to have a different entry level regarding sleep apnea, but ours is we treat it aggressively. So additional thoughts include that you are attending some form of a support group on a regular basis, right? That you're not isolated, that you're talking to people who are walking very similar journeys as you, that you're also committed to hard work, right? That you are committed to determination and that you are committed to yourself. You cannot go through this and continue to prioritize everybody else's needs and priorities for what you do with your time in front of your own needs. You have to prioritize yourself in your day. And I've said it before and I'll say it again. It is a gift to the people that know you, love you, count on you, that you take better care of yourself, because you're going to be more present at the time that you're present with them, and you're going to be more present longer. We're talking years. So quality, quantity. Okay. Take care of yourself. Now, okay. I started out by talking about all the causes of obesity, right? Western diet, injury, disability, medications, hormonal imbalances. And now I've said, okay, we've got surgery. And and we kind of put surgery on top of all of those things. And it's got to make you wonder, well, what are we doing about, is surgery a one size fits all? And how does surgery help with genetics? Does it? So we're going to kind of work the list backwards. I think I've made the case that the hormonal changes that happen, and we're talking about gut and fat hormones that talk to your brain, are now, rather than working against you, working for you. And you only get that at this point. We don't have a pill for that. Okay. You can't think your way around that. Only bariatric surgery that gets that kind of gut hormonal changes. Okay. What about bacteria? Does bariatric surgery change the bacteria in your gut? Well, we're not really sure, but I think possibly if you're eating a healthier diet, maybe you're taking more probiotics, you're going to have a healthier gut. But the jury's kind of still out on that, so stay tuned. Okay. Does bariatric surgery change the stress in your life? Okay. Not necessarily, right? It's not going to put money in your bank. It's not going to save your marriage. It's not going to get you a job promotion. Those stressors are still stressors in your life. Okay, so you need to kind of address those. I do think that bariatric surgery allows people an opportunity to have what I call adaptive coping. You look at the prices that you're paying for the stress that you're taking in your life, and you're feeling like, you know what? Maybe it's a relationship at work that's too toxic, and you can just walk away from that relationship. Or change the dynamics, have some adaptive coping within your life. Okay. You learn a new set of skills. Maybe you also learn that because you're in counseling and you're going to support group. Okay. And maybe your support group is on Facebook and it's a loving, supportive bariatric surgery Facebook group. Okay. Sleep deprivation. Well, CPAP, people are getting on CPAP, and also with weight loss, they're generally sleeping better. Okay, whether they're able to get off their CPAP or not. Many people are able to test off of their CPAP after losing weight. Not everybody, but many people. So sleep quality does go up. Medications. Yeah, people are taking less meds, and those meds are taking less meds helps prevent weight regain, and also we could say arguably helps support further weight loss. What about injury and disability? Well, now you can heal. Now you can go back to that orthopedic surgeon and get the repair that you need. Okay. So we have a win there. What about portion sizes and food abundance? Well, portion sizes definitely go down. Absolutely. And awareness goes up. You learn more awareness about the social cues that are happening to drive you to consume. And maybe you're more savvy to it and more resilient against falling prey to those social cues. Social nature of food, right? I mean, we're still going to get together and celebrate. But maybe rather than feasting 100% on the meal and not talking, maybe now you're talking more to people and focusing more on the conversation and really finding out what's going on with your long lost cousin and listening to them and forging those bonds, right? Connection. So psychology, does a healthier person equal a happier person? Maybe, maybe not. Again, what about the 7 deadlies, right? Depression, emptiness, anxiety, disengagement, loneliness, isolation, shame, the numbing behaviors. Okay. So I nod to Brene Brown. I want to give you 3 ways out of numbing and into healing. Number 1, learn how to actually feel your feelings. Recognize them, give them a name. Oh, this is sadness. Okay. What am I sad about? I'm not really sure. Okay. I know I'm sad. Oh, this is boredom. I don't have to eat. I'm just bored. I'm going to go for a walk. So learn how to feel those feelings. Number 2, stay mindful to your numbing behaviors. What is it that you do when you are seeking to numb? Because in that pause of mindfulness, where you're aware, you're savvy to yourself, you have opportunity to change, to choose a different path, right? Number 3, learn how to lean into the discomfort of hard emotions. Sometimes people tell me, if I lean into that, it's going to be a free fall. I'm going to start crying and I'm never going to stop. It doesn't happen. You lean into it. You take it on one step at a time. And if you need to get counseling, get counseling. Okay. So I do agree with the AA sentiment of our secrets make us sick. Okay. So it is important that you own your story and you talk about it. Own your story, talk about it. Don't let your secrets make you sick. Go to support group, whether that support group is specifically a bariatric surgery support group, whether it's an in-person one, whether it's online, whether it's checking in with your loving Facebook community. Again, Facebook I'm a big Facebook fan, but I also recognize that it's not necessarily a substitute for real human interaction. So I also think that Overeaters Anonymous pairs quite well for people that's applicable to. Alcoholics Anonymous, Narcotics Anonymous, etc. Any of the 12-step programs. If that resonates with you, boy, go for it. Read good books on personal growth and development. As adults, we just think that we should know how to know all this stuff, and we don't. Emotionally, I feel like often we sort of left off as 15-year-olds, and we don't know how to negotiate the world. We know how to pay our bills. We know how to go, get married, say I do, and be in a committed relationship, but that doesn't mean that we necessarily know how to negotiate the feelings that are within our head and our heart. And I can't tell you how important reading books on personal growth and development has been for me in my journey, and also for the patients that I've taken care of. And you guys know me, right? Brene Brown. If you want a place to start there. If you want other suggestions, I got more where that came from. Okay. Journal. Please journal, right? And if you don't know what to journal and you're not somebody that wants to write exposés on he said, she said, and how you feel, that's fine if you do and fine if you don't. But when in doubt, write 3 things that you're grateful for every single day. Just 3 things. Okay. Start with gratitude. Always start with gratitude. Hang out with positive people. So that's also the gratitude thing, right? Hanging out with positive people. You get what you give, and hanging out with positive people kind of feeds that part of us that we definitely need to have fed. There's lots of negativity out there, but seek out positivity. Begin and continue counseling if that's relevant for you. And I think that for the vast majority of us, at 1 or 2 or 3 points in our lives, some counseling with a therapist who's a trained professional to help us figure out how to think about our thinking has a role to be played. I know I've been in counseling 2, 3 times in my life, from teenage years into adulthood. And, each time was for an episode that was kind of felt to me at the time like, hard, didn't know, like being in a dark room where I didn't know where the door was to get out, and talking to a therapist, normalizing that my feelings were my feelings and I was entitled to them, gave me a way out, really made a huge difference. So spirituality and faith, I also think, is important. Now, you don't need to believe in a deity, God, or whatever. That's not, great if you do. It's not necessarily what I'm talking about. I'm just talking about connecting to something, a higher power than yours. Maybe that's just walking in the woods and touching tree bark. Like, whatever that thing means to you that connects you to spirituality and faith, I think it's important. Creative outlets, absolutely. Pick up a guitar, draw, paint, clay, knit, walk. I said for years that yoga was my creative outlet. It still is. Podcasting is also now my creative outlet. So find some way to feed your spirit. And humor. Oh my goodness. Right? Don't forget to laugh. And stay tuned at the end of every single one of my episodes for my kid jokes. I think I'm going to do one at the end of this episode, but oh my God, I'm already to 1 hour and 30 minutes. Oh boy. Okay. So healthier equals happier? I hope so. I really, really hope so. But you got to do your work. Genetics, does bariatric surgery change your parents? No. But it can help change your epigenetics. What is epigenetics briefly? It's basically the clothing that your genes wear and how your genes interact with their environment. There's some data that shows that the coding of our genes gets changed by having bariatric surgery. Low activity level turns into more activity. People are more active after bariatric surgery, and that's because they've been hearing it from their program, they've been hearing it from other people, and they also are feeling better. And they're getting the results, right? And that getting results encourages you to continue going. Western diet transitions into a healthier diet, okay? Without a doubt. You just are eating healthier, smaller portions of whole foods. So, okay, 1 hour and 30 minutes. In conclusion, this is really what I want you to know. I began by talking about not confusing simple for easy, right? Now I want you to know that nothing that I've discussed here has been simple or easy, right? Nothing that I'm talking about is simple or easy. The truth is, this is all complicated and it's hard. But I'm also willing to bet that you're already familiar with complicated and hard in your life. You already know complicated and hard. I love the expression, a pessimist sees the difficulty in every opportunity, and an optimist sees the opportunity in every difficulty. So, now's your time. Be an optimist. See the opportunity in all that difficulty, in all those challenges. And pick your battles, right? Pick your battles. You totally can do this. Bariatric surgery, and you, I should say, with the help of bariatric surgery, can rewrite your future. And I want you to know, above all else, I believe in you. I really, really believe in you. And thank you for believing in me. Huge thanks to my educational mentors who've helped me, only one of whom I've ever met in person, but they have influenced everything that I've just told you. And those are Brene Brown, Dr. Randy Seeley, researcher scientist, Gary Taubes, who's a science writer. Totally recommend his books. Got one sitting right here, Why We Get Fat and What to Do About It. Excellent book. And Dr. Lee Kaplan, who's a researcher scientist. Shout out to those educational mentors. Go to my website, weightlosssurgerypodcast.com, for links, Like the podcast in iTunes. That really helps people find it. Share this with your family, friends, coworkers, and maybe even bariatric surgery programs. Okay. And that's it for now. Take care.
The information provided on this podcast is for general educational purposes only and is not intended to diagnose, treat, cure, or prevent disease. Nor does this information create a patient-provider relationship. Consult your personal licensed healthcare provider about your health concerns before you undertake any health-related regimen or program, or before ingesting any vitamin or supplement products. WeightLossSurgeryPodcast.com.
Okay, here's my kid joke. My husband just told me this one. He's a second grade teacher, so he should know. Okay, the joke is, why was the broom late for work? Because it overswept. Thanks, honey.